This lecture will focus on the respiratory system. Now, the respiratory system is one that we often kind of touch on while we talk about a lot of other systems. And in and of itself is a relatively simple system, but it has so much involvement, or so much, I should say, it has to have so many other systems involved in order to make it work. So it has to have that circulatory system to help circulate the actual gases that it exchanges, or that it takes in and exchanges within the body. It's got to have the skeletal muscles to help make the system function. We're going to talk about that. It's got to have the nervous system to coordinate the system at the same time. So it really is a relatively simple system to think about, but it's got so much pervasive help from all these other systems as well that we're going to talk about. Now, there's two aspects of the respiratory system that we have to keep in mind. There's the conduction portion, and that is the piping, so to speak, the tubing. So think of ventilation in the house, right? You've got a furnace or an air conditioner that actually does the heating or the cooling, right? I realize that's not analogous to something in the body per se, but it's as close as we're going to get. That would be the respiratory portion. So that's there for the actual function and goal. But the conduction is all the piping inside the home, inside your house, to get that air to the different rooms in the house. And this is often overlooked. It's often not thought of as being as important, and often not recognized for the sheer necessity that it is. Right? So we're talking about the nose, the nasal cavity, the pharynx. These are all piping into the body, along with, as it turns out, the mouth as well. The mouth is an entrance for air as well. The pharynx, the larynx, the trachea, and all the progressively smaller airways from the primary bronchi all the way down to the bronchioles within the actual lungs. These all serve as tubes, and their job, very simply, is to bring air in or get air out of the body. That's it. But it's such a huge function. The respiratory portion is a much smaller set of structures, but its job is much larger. So it is there for gas exchange. We're going to take oxygen in to the blood, and we're going to swap that out with the carbon dioxide that was in the blood that now needs to be exhaled and gotten out of the body due to its toxic level, or due to its potential for toxicity. So these are the respiratory bronchioles, the alveolar ducts, and really the driving structure behind these are the air sacs, what we think of as the alveoli. Now, respiratory functions, pretty simple here. Breathing, right? That's the biggest one, right? It's two cyclic phases. We can either think of inhalation, which is the most common term, or for whatever reason, the other term is inspiration. So you inspire. Personally, I find that one to be a tad bit confusing because inspiration is used so many different ways that I don't think that's necessarily helpful, but that is a correct term. Exhalation, breathing outward, again, or outside, is obviously, again, the most obvious name for this process. Expiration, I think, is an even worse term than inspiration because it sounds a lot like death. And so, I mean, you can use expiration, you can use inspiration. These are perfectly appropriate terms. I will use inhalation and exhalation because I think they're just obvious. Gas exchange, obviously, is the reason behind breathing. So I in that respect, it should really go hand in hand with that notion. Sound production, this is one that we don't often think about, right? The ability to actually talk, to make noise, to communicate with one another, right, meaningfully. That is a huge goal, or a huge function of the respiratory system that I think is often kind of neglected. I think makes sense. Olfaction is another big one. The ability to smell wouldn't exist without the respiratory system and our ability to breathe in and out. And then finally, defense. We've got to have some defense of our body, both from the air that we're breathing in and the things within that air that we're breathing in. Lastly, in order to operate properly, the respiratory system must filter the air that's coming in, and that in turn plays a role here in this idea of defense. it must humidify the air and warm that air, which again also serves a defense function. Now, looking first at the upper respiratory tract, we're talking about the nose, the nasal cavity, the paranasal sinuses, and the pharynx. All these structures are aligned with a very specific epithelium that we've already talked about in lab, we've already covered, and that is that pseudostratified ciliated columnar epithelium. So this is a falsely layered, that's what pseudostratified means. It means it's got false, it appears to be falsely layered, and in fact it's only a single layer of cells. These cells are ciliated. They've got cilia that hang off of the cell membrane that allow them to sweep through the air and pick things up, and that is particularly important. They're column-shaped cells, so they're elongate cells, and they're an epithelium, which means they're going to line these open cavities, which in this case happens to be these spaces and passageways. Embedded in this tissue are goblet cells, and goblet cells produce mucus. So we've got mucus lines this tissue and is there again to catch and trap foreign things as we breathe in, and then the cilia are going to beat that mucus in one of two directions, either towards the stomach to be destroyed, or out up the nose or out the mouth so we can be coughed up and released that way. Now, the nose and nasal cavity, we've got structures within the nose that often tend to confuse students. The first is the internal nares. Internal nares are really just the nostrils right here. So this is the internal opening, right? Remember, we've got two of those, right? So there's a left and a right one. That's often, again, it's lost when you look at this particular view, but you've got two internal nostrils. You've also got two external nares or nostrils, and this is that narrowing funnel as we're leaving the nose or nasal cavity and entering the nasal pharynx. This is an internal nostril. The vestibule is this space within the actual external nares that has hair that protrudes from it in some of us, and some of us more prominently than others. The nasolacrimal duct is seen here, although again, I'm not going to cover that much. The concha, these are particularly important. These structures here help to separate airflow for better filtering. And then you've got the hard and soft palate. So the hard palate, soft palate both separate the nose from the oral cavity for a lot of good reasons. The nasal septum, not seen here, would divide this chamber from, say, the left chamber, right? So you should see, in order to see this, the nasal septum must be removed from this view. But if the nasal septum were here, it would look like a wall was here, and you couldn't see anything past it. So it's a good thing to keep in mind. The nasal septum is formed by three structures: the vomer bone, the perpendicular plate of the ethmoid bone, and then finally the hyaline cartilage that exists more anteriorly that helps make up the portions of the nose that we most associate with the look of a nose. And it's also there just to make sure that if we run into a door or a glass door or whatever the case may be, that it's not bone that's being broken there, it's just cartilage. The bones that help make up the nose and nasal cavity are going to be the maxillary bone, nasal bone, frontal bone, ethmoid bone, and sphenoidal bone, all helping to make up that cavity. Now the paranasal sinuses, these are those open cavities within a bone. So they're within the frontal bone, or within the ethmoidal bone, or within the sphenoid, or within the maxilla bone, right? So these are kind of internal caves within the bone. And their functions are to decrease skull bone weight. We're bringing down weight so that our neck doesn't have to be more muscular and thicker than it actually is. It also plays a big role in actually producing sound, helping in resonance of speaking to help deepen and produce the sound of our voice that we actually have. It communicates with the nasal cavity via ducts, and so we see a lot of these ducts here. Here you see some of these ducts leading from the maxillary into the nasal cavity, from the ethmoidal labyrinth into the nasal cavity. You can't really see them too well for the frontal, and you definitely can't see them from the sphenoidal, but they do exist. These are lined with, again, with that pseudostratified ciliated columnar epithelium. The pharynx is a tube, right? And we've got three specific regions that we're going to talk about that need to be talked about. Now, the space is used for both respiratory and digestive systems, although not always. Obviously, the nasopharynx is used less for digestive and much more for respiratory. Oropharynx and laryngopharynx are going to be used for both digestive and respiratory. The pharynx originates posterior to the pharynx, posterior to the nasal cavity for the nasopharynx, posterior to the oral cavity for the oropharynx, and it's going to extend inferiorly to the larynx and esophagus for the laryngopharynx aspect of it. It is lined by mucosa, and it's going to have a lot of skeletal muscles there to allow for swallowing, to help aid in swallowing. The uvula here is the very tip of the soft palate that's going to swing backward and close off the actual nasopharynx when food is either coming up, so i.e. vomiting, or when food is coming in to make sure that food doesn't back up into the nasal cavity. Because either way, we don't want either partially digested food or fully digested food up in the nasopharynx. Now, the uvula is sometimes, unfortunately, confused with another reasonably similar term called the vulva. The uvula is in the mouth. The vulva are the external genitalia for females. Please do not confuse these two terms, right? Because the spelling is similar enough that I can sort of understand the mistake, but they're on ridiculously different ends of the body and only in some of us. So that's an important important distinction here to make. Uvula is part of the soft palate in the oral cavity. Now, the pharynx, as we talked about, is partitioned into regions. We're going to talk about those now. The nasopharynx is the superior region of the pharynx. It's, again, typically only used for air. The posterior wall has a single pharyngeal tonsil, often called the adenoids. The lateral wall has the paired auditory tubes that connect the nasopharynx to the middle ear, and this allows us to equilibrate pressure in the middle ear so that, again, we don't have pressure building up in the middle ear where it causes distension and or damage to the inner ear or the outer ear, i.e. the tympanic membrane. So this is what the auditory tubes are actually what you're squeezing and exercising when you swallow, when you yawn, when you chew gum, whatever you're doing while ascending in an airplane up an atmosphere to again equilibrate this pressure. So that's what all that popping in your ears comes from. The oropharynx is the middle region of the pharynx. This is immediately posterior to the oral cavity itself, is common to both respiratory and digestive systems, which means depending on when you use it, you're going to be using it for either respiratory or digestive functions. The palatine tonsils are located here along the lateral walls, both right and left, and also the lingual tonsils are located at the base of the tongue. So we've got actually 3 tonsils here, 2 different types, palatine and the lingual. Finally, we have the laryngopharynx. This is the inferior portion of the pharynx. This is going to extend inferiorly from the hyoid bone to the actual larynx and esophagus. It's lined with a non-keratinized stratified squamous epithelium. That's there as a layered tissue to permit food passage as it narrows. It also obviously permits the passage of air too, but the layered stratified squamous epithelium is there to help resist the damage that might be caused by swallowing certain types of foods. Now, the lower respiratory tract, again, this is still conduction portion of the respiratory system overall. And these are the larynx, the trachea, the bronchi, the bronchioles, and their associated structure. But now we're going to also have some of the respiratory portion as well. That is the respiratory bronchioles, alveolar ducts, and finally the alveoli that we find in the lower respiratory tract as well. The larynx itself is a short, somewhat cylindrical airway, it's kind of cylindrical. It's kind of a weird way to describe it, but it is. Bounded posteriorly by the laryngopharynx and inferiorly by the trachea. So we see the trachea come off the inferior aspect of the larynx. And the job of the larynx is to prevent swallowed materials from entering the lower respiratory tract. This is obviously very bad for us. If we're breathing and we're taking in swallowed actual food, this would be very bad. It would cause a great deal of damage, both from infection and just pure blockage to air. It's there to help conduct air into the lower respiratory tract. It's there to help produce sound. We'll talk about that. And it is composed by a framework of 9 pieces of cartilage. Please understand, though, that there are not 9 differently named pieces of cartilage here. That's important. But they are, in fact, 9 pieces of cartilage that make up the larynx. The cartilages that we find here, these are individual cartilages. The thyroid is a very large one up front or anteriorly. The cricoid is a smaller, less inferior, but anterior cartilage as well. Epiglottis is more deep within the larynx. And then, so you've got 1, 2, 3 individual pieces of cartilage plus 3 pairs of smaller laryngeal cartilages. So you've got 2 arytenoid cartilages, 2 corniculate, and 2 cuneiform. 2, 4, 6, 7, 8, 9. That's where the 9 different pieces of cartilage come from. Now, the vocal ligaments are sometimes called the vocal folds. These are considered to be the true vocal cords because they actually produce sound. Whereas the vestibular ligaments, sometimes called the vestibular folds, are more commonly called the false vocal cords because they have no function in sound production, rather are there to protect the actual vocal cords, the true vocal cords. And sound is produced through these true vocal cords by the tension, length, and position of those vocal cords. And that ultimately determines the quality of the sound. Here is an anterior view of the actual larynx, and here we can see the thyroid cartilage, and right at the center here is a peak called the laryngeal prominence. Inferior to it, we can see the cricoid cartilage here, and if from a little bit on top, and if we look at a posterior view, we can see that large, almost tongue-shaped looking epiglottis. That's there to swing backward and close the trachea off to swallow the food. And we also see here the cuneiform cartilages, the corniculate cartilages, and finally the arytenoid cartilages. 6 small pieces of cartilage all seen in the posterior aspect of the actual larynx. This would be a laryngoscopic view of the actual vocal cords, where you can actually see the vocal folds lining a space, that space being called the rima glottis, that is that actual space there in which air passes. And then you've got the actual vestibular folds here, here, and here that actually help protect the actual vocal folds. So again, recognize the fact that these are not, these structures are not actually vibrating and or producing sound, whereas the vocal folds are going to actually vibrate because they're coming into contact with air on that, at that rima glottis, and actually vibrating to produce sound. We can see how the arytenoid and arytenoid cartilages move and change position in order to change the position of the actual vocal folds in order to actually produce sound. Okay, now the trachea. The trachea is a flexible, slightly rigid tube that branches into left and right primary bronchi, and that would obviously be to serve the right lung or the left lung. So this is the main pipe running inferiorly that's going to actually conduct all the air to the lungs. It's supported by these 15 or 20, depending on the person, C-shaped rings or cartilaginous rings that help keep the trachea open at all times, so it should not collapse on itself. Never should the trachea collapse on itself. The annular ligaments are found in between. You can see these ligamentous structures in between each set of tracheal cartilages here. The esophagus is actually posterior to the structure, and this can actually collapse on itself because it's the esophagus. You're going to be bringing down liquids and solid food through there, so it will actually open up with that swallowed food and or liquid. The bronchial tree literally does look like a tree. It just looks like an upside down tree. It's a highly branched system of air conducting passageways that originate from the left and right primary bronchi. And I'm going to go ahead and flip forward one slide just so you can see. If you look at this, this is that whole bronchial tree that I'm talking about here. And it does. It looks a lot like a tree. Imagine for a moment that if you rotated this 180 degrees, all of a sudden it would kind of look a lot like a tree. Because just like a tree that has an incredibly highly branched system to get a lot of leaves out in order to in order to create such a high amount of surface area to pick up light for photosynthesis, the bronchial tree is doing the same thing, just inverted, to pare down this air into such a highly high surface area within the lungs so that we can get as much oxygen out of that air as possible. Now, the left lung has 2 secondary bronchi. That's due to its 2 actual lobes. The right lung has 3, again associated with its 3 lobes. And those secondary bronchi will then further divide into what we call tertiary bronchi. Now, these will progressively branch into narrow and narrower and narrower tubes, ending at structures we call the terminal bronchioles. Now, the left and right primary bronchi enter each lung through a structure we call the hilum or hilum. This is also where the pulmonary vessels and the lymphatic vessels and the nerves all enter the actual lungs. So again, we see the left primary bronchus here and the right primary bronchus here, and the actual left primary bronchus is entering this lung through a structure you can't see here called the hilum. We're going to move forward one slide so you can actually see that hilum here and that hilum here. It's actually a depression on the medial aspect of each lung that allows these vessels to enter each lung. Now, the respiratory bronchioles and alveolar ducts are lined with a simple columnar or cuboidal cells without cartilage to keep them open. So these structures are actually not held open by cartilage. And the respiratory bronchioles lead to smaller structures called the alveolar ducts, which lead to the smaller structures we call the alveoli. And this is where we see actual gas exchange occur. Now, within these small tubes, we have bronchodilation, which is controlled by sympathetic innervation, and bronchoconstriction, which is controlled by parasympathetic innervation of the smooth muscle of those bronchioles, which allow us to actually dilate and make these vessels wider or constrict them and make them smaller. This is where asthmatics find their issues with breathing, is this deep in the actual lungs near the the gas exchange area of the lungs. Now the alveoli have extremely thin walls. This is 1 cell layer thick. These are sacs. So we see it's actually a sac, a sac, a sac, a sac, a sac, a sac, and it's these little sacs that gases run straight into and diffuse across that single cell layer thickness into the capillary beds that surround each one of these alveoli. And that allows us to actually exchange gases. Carbon dioxide is going to leave the blood, entering the alveolus to exit the lungs and the body eventually. And oxygen, in the same respect, is going to diffuse into the blood and leaving the lungs, specifically so it can get to the body tissues. They have a very spongy appearance. Lungs contain approximately 300 to 400 million alveoli. Now, in addition to just that tissue layer, that single cell layer epithelium, we've got a couple of different cells inside the alveolus to help maintain the function of the alveolus without doing any actual gas exchange. The first is called the septal cells, sometimes referred to as the surfactant cells. And these cells produce an oily substance that counteracts the existence of tiny, small amounts of water that gets breathed into the lungs. Every time we breathe in air, there's water vapor that's actually in that air. And so if that water vapor actually beads up and collects inside the alveolus, then water has a very strong attractive force to itself. We call it, forms this bonding between each molecule. And so it would actually close up the alveolus by this strong attractive force between water lining this tissue. But the surfactant cells, or the septal cells, with the oil disrupts that tension, that surface tension of the water, keeping the sac open. Also in here, we do have macrophages. These are meant to be phagocytic. They're meant to be an immune system involvement within the respiratory system. Now, looking at the lungs from a gross anatomical perspective, the lungs themselves are actually found in the pleural cavity. So you've got a pleural sac that surrounds the actual lungs. And this functions a lot like the pericardial sac that we've talked about before. It's there for protection and to keep these things from moving around too much. And you've got an apex at the top and a base at the bottom, exactly the way you would expect an apex and a base to actually exist. Again, very much unlike the heart in that respect. The right is a broader lung. It's got 3 lobes, the superior, the middle, and the inferior lobe. And it's got 2 fissures. It's got the horizontal fissure here separating the superior and middle, and it's got the oblique fissure running at an oblique plane separating the middle and inferior lobe, respectively. Now, the left lung, however, only has 2 lobes. It's longer, and it has only a single fissure called the oblique fissure that separates the superior and inferior lobes of the left lung. Now, the pleura is the outer surface of the actual lung. So the visceral pleura is the actual outer surface of the lung. Now, remember, there's a sac around the lungs, and that sac is formed by the parietal pleura. And that sac would cover the lungs. So if you can see a sac around the lungs, you're looking at the parietal pleura. If you can see the actual lungs, you're looking at the visceral pleura. And these pleural layers are continuous at the hilum of each lung. And we can see these a little bit better here by looking at the actual sac along with a dissected portion away, where here, if I'm looking at this view, notice that I can see 1, 2, 3 lobes. Here, I can see the lobes, I can see the outside of the lungs. I'm therefore looking at the visceral pleura. But if I look here, for example, I can only see the sac, so I'm looking at the parietal pleura now. And we can see the parietal pleura is more superficial, whereas the visceral pleura actually lines the outside of the lungs, and that is deeper. These pleural membranes produce a serous fluid, just like we saw in the pericardial sac, that acts as a lubricant, minimizing friction during breathing. Okay, so looking at respiration, we need to think of the changes that take place within the actual thoracic cavity that allow respiration to occur. And the interesting thing is the lungs don't actually move. That is, they're not being stretched, or they're not actually inflating themselves, but rather they're responding to changes in the size and volume of the thoracic cavity. So when the diaphragm contracts, this in turn increases the volume of the thoracic cavity. And by doing so, natural diffusion causes air to move from the outside of the body into the actual lungs to equalize atmospheric pressure between the outside of the body and the inside of the body now. And so air comes in. So that's how we breathe in. When the diaphragm actually relaxes, when it just stops working and relaxes, that volume is now decreased, and we can see that here, right? And it's the volume of this when we take a gas and we same amount of gas, but now we're decreasing the size of the container that it's in, i.e. the thoracic cavity. Pressure should increase. So now we have an unbalance of pressure between the inside of the body and the outside of the body. And so now, naturally speaking, air molecules want to run out of the body to help equalize that pressure, and air goes out. This is called Boyle's law, and that is the pressure of a gas decreases if the volume of the container increases and vice versa. So very simply put, the air that exists in the lungs prior to us contracting our diaphragm is at a pressure that is consistent with the external atmospheric pressure. And the second that we contract our diaphragm and expand the size of the thoracic cavity, we're increasing the volume. Now, as volume expands, the gas that's inside there now gets to spread out, and the pressure is decreased significantly. And therefore, we want to equilibrate that pressure, and air molecules naturally move inside the body to help equalize that pressure. Same thing. Once you've breathed in, you've got all this gas, and now you're relaxing your diaphragm. You're decreasing the size of your thoracic cavity, and all of a sudden you're taking a lot of gas molecules and you're compressing them into a smaller volume. This in turn increases pressure. And as pressure increases, now we've got an unbalance where pressure is higher inside of the body relative to the outside of the body, and air naturally moves outward. And so that is essentially the description that we see in both of these slides here. Now, let's think about the muscles that move the ribs that help with inhalation and exhalation. The external intercostals, these are the muscles between the actual ribs, and these are the superficial muscles between the actual ribs, are going to elevate the ribs, increasing the thoracic chamber during inhalation. Additionally, we find the scalenes, the pectoralis minor, the serratus anterior, and the sternocleidomastoid help with forced inhalation. So this is not a normal breath in, but rather a deep breath in. That's a forced inhalation. Normal exhalation, interestingly enough, requires no active muscular effort. The diaphragm is just going to relax, and therefore we see normal exhalation. However, if you want to force exhalation, now all of a sudden you must contract your internal intercostals and also employ some of the abdominal muscles to assist in that active exhalation. Ventilation control by the brain is not something that I'm actually actively going to test you on. With respect to the respiratory system, I will talk about it a bit in the nervous system, but we'll get there a little bit later on. But this I kind of wanted to real quick discuss. The larynx, trachea, bronchial tree, and lungs are all innervated by a system we call the autonomic nervous system. This is the involuntary nervous system, the automatic nervous system, if you want to think of it that way. And this is the constriction and dilation of the tubes in that system. The involuntary rhythmic activities that deliver and remove respiratory gases are regulated by the brainstem. And it's the pons that ultimately controls both the ventral respiratory group and the dorsal respiratory group. Don't worry about the medulla oblongata in terms of this here. We think of the medulla oblongata as just simply controlling rate and depth of breathing. That's the intensity that I would ask you in the nervous system per se.